Thank you, Nikki, and I'd like to thank the organizers of the meeting for asking me to give a talk on head and neck anatomy. I know you guys gave me the easiest talk of the day to summarize head and neck anatomy in 40 minutes. Piece of cake, right? So first of all, I don't think there's any way that I can overstate the importance of medical dosimetry. I think that, from a physician's perspective, you guys and gals are really the behind the scenes people who really make the plans work, who really benefit the patients and really do a great job. I know, just from listening to the talks here, you guys have multiple hats that you're wearing, including documentation, billing, and of course your dosimetric work. And I would argue that, despite all the other hats that you wear, the hat that involves patient care is really the most important one. And so I hope that this talk will kind of add to that perspective. I know you've heard a lot about documentation and billing, which is also just as important in some arenas. So first of all, I just wanted to thank you all for what you do for patients, namely. I'm based out of Charlotte, North Carolina. I work with a large group of radiation oncologists, Southeast Radiation Oncology, and I'm very fortunate to work with a great group of dosimetrists, some of whom are in the audience as well. So a little bit, Nikki kind of told you a little bit about my background, and I think life is interesting. I, trained at the Cleveland Clinic. I went to medical school, all that stuff, but really I think you learn what you need to know when you're in practice. And there's a big learning curve when you come out of residency or fellowship, when you're ultimately responsible for the plans and what's happening to the patients and contouring as well. And so, frankly, when I was at the Cleveland Clinic, we weren't doing a lot of IMRT, so a lot of this talk is based on information that's come since then, and it does incorporate my information from my training as well. So while I don't expect this to be a life-changing talk for anybody, I do hope that it will be something that you guys can take back to your clinics and incorporate into practice. So, I think context is very important. I've sat through many talks like this in many meetings, and you sit here and you say, oh, piece of cake, I understand everything I need to know about head and neck anatomy. But really, when you get back to your clinic, that's where you need to apply what we talk about here, whether it's documentation, processes, flows, or head and neck anatomy. And so, here's a picture that actually my dosimetrist sent me that I was looking at with her. And, if you're going down the street, you say, wow, that's a beautiful rainbow. And then you say, wow, it's a double rainbow. Fantastic. It's even better. And so, but I think the context of where you see this picture or this scene is completely different depending on where you're at. Sitting in dosimetry, looking at this picture, I said, wow, that's a fantastic IMRT plan. Look at how close those lines are together. And then I said, oh my gosh, it's even better. It's a SIB. Look at that. There's another set of isodose lines that are just as tight. So again, the context here is that you guys will hopefully understand what I'm talking about, but be able to take it and apply it to the clinic. So I did change some of the objectives that are listed in your handout there. And really, I'm trying to make this more of a practical talk. We want to identify the landmarks in the head and neck region. We want to use this information to critically evaluate target and organ structures at risk and obtain practical information to integrate immediately into clinical practice. Those are really what my goals are with this talk. So we'll just go through some background information and then start in with the intracranial structures. And I don't know if that was part of the scope, but I figured the intracranial structures can sometimes cause some anxiety, and so we should cover the chiasm, the orbits, the brainstem, and the cochlea. Then we'll move on to the nitty-gritty, the head and neck structures, the spinal cord, oral cavity, mandible, parotids, pharynx, submandibular glands, larynx, esophagus, and the brachial plexus. And then we'll talk about some other miscellaneous topics and question and answer. And again, not to understate the importance of radiation therapy in the treatment of head and neck cancer. It's a high-dose radiation is a mainstay of treatment, whether it's in the post-operative period or whether it's used with chemotherapy in a definitive setting. So these are high doses, and there are a number of critical organs that are in the area. And overtreatment or the overtreatment of these organs can cause significant morbidity, whether it's xerostomia, myelopathy, or other issues. And lastly, the head and neck region has complex and very intimidating anatomy, not unlike speaking up here. So, but I think since training, really it's been an explosion of resources that are available to assist with this intimidating task of contouring the head and neck. And, historically in medical school and since then we've used Netter's Atlas and Gray's Anatomy, not the TV show, but the book. And then there are a number of published papers, which we'll go through a couple of them, that I found most helpful in my day-to-day practice. And RTOG, I'm going to focus a lot on RTOG because, frankly, it's a group of experts across the world who have published their guidelines and contouring atlases to help us with our day-to-day practice. And then in addition, there are some web resources that can be used on a day-to-day basis as well to help with normal anatomy. So the format of the talk will go from head to toe, at least in the head and neck area. We'll start at the top, go through the intracranial portion, and then we'll go down to the brachial plexus. We'll use RTOG definitions. The RTOG protocols that are out have changed over time, and they're actually quite intimidating. Some of the protocols are 70, 80, 100 pages, but they have very, very good information in them to help with daily practice, whether the patient is on a protocol or not. And then we'll use photographs and diagrams from Netter's Atlas and Gray's Anatomy, as well as CT data and MRI data from actual patients in our clinic. So the CT simulation data, this is key. This is very, very important. And I've been to several centers which have thicker slices, which have different CT simulators, and it does make the job harder. And so target and organ at risk delineation are directly related to the quality of your CT data. We have a GE Lightspeed RT16 multi-slice with a wide bore. We use 2.5 millimeter slices without contrast. We do not use IV contrast in the clinic. And for head and neck planning, we use retrospective reconstructions, which helps to reduce the noise ratio and allows for better anatomic delineation. So some basic concepts and abbreviations. Again, a lot of this stuff you guys already know, but let's cover it just to be thorough. The OAR is the organ at risk. This is the specific organ that we're trying to avoid. The PRV, which is the planning organ at risk volume, is basically the same concept as is used for PTV construction. When you have a target, you use a GTV, and then from that, you make a CTV, or the physicians do. They make a CTV to delineate the microscopic area of extension, and then a PTV, which helps to account for motion or setup variability. So the same concept can be applied to the organ at risk, and that's what we call the PRV, or the planning organ at risk volume. Now, in the head and neck region, this is outlined in very much detail in the RTOG protocols. And, we have very good immobilization for head and neck. So the PRV volumes are typically pretty small, in the order of 3 to 5 millimeters on top of the OAR. A lot of times we use fusion in the head and neck region, especially in the brain, and sometimes we'll use PET fusion. It allows better delineation of the target volume. But please remember that the CT sim data is really the king here. So if you're using MRI fusion to contour let's say the optic chiasm, we need to be very careful to make sure that correlates with what is on the CT data, because it's sometimes difficult, as you guys know better than I do, to have a good registration across the whole data set in all planes. So just a gentle reminder there to make sure that we review, if you contour on the MRI fusion, just to review the CT sim data as well. And finally, a couple other things. There's a volume effect, and again, we look at not only just the point dose, or when you look in evaluating a DVH, but really where does that correlate on the volume. And the volume that RTOG typically uses is 0.03 cc's, and we'll go into that a little bit more. So a point dose may be acceptable as long as it is literally a voxel, or very small area. So sometimes using the DVH, you can calculate out to see what the real dose is at a 0.03 cc volume. And then contouring papers, I have to mention this as a bit of a disclaimer. I'm no expert by any stretch of the imagination as far as contouring or head and neck anatomy, but I think what you'll see is that the experts may not even be experts. There are various contouring papers out there for all different sites, and I think there's high variability as far as contouring. So this is just one way in which I approach head and neck contouring. So let's get right into it. If we talk about the optic chiasm, That's obviously a structure that causes a lot of angst and discomfort when we mention it, as far as contouring and also as far as dose. So if you look at 2 recent RTOG protocols, the disease that they're treating, the prescription dose for the protocol, and the OAR max dose, again, keeping in mind that it's a 0.03 cc volume. 0539 is a protocol that treats meningiomas, and the prescription dose is from 54 to 56 gray, and their OAR max for the chiasm is 54 to 56 as well. I'm sorry, 54 to 60 gray is the prescription dose. Now, if we take a different disease site, GBM, or a different disease process, GBM, which we all know is a bit of a more challenging diagnosis and prognosis, then the prescription dose remains at 60 gray, but the OAR max dose approaches 56 gray for a volume of 0.03 cc's again. If we look at the anatomy of the optic chiasm, what you can see is visual data comes from the outside and travels in the retina and comes back through the optic nerves and then crosses here, which is the chiasm. Anything before the chiasm and closer to the orbits is the optic nerve. Anything past the chiasm is the optic tract. Really what we're concerned about when we're contouring is this structure right here. This is the chiasm. Now it's very difficult to see that on most CT or even sometimes MRI data sets, and so we'll kind of make it a husky chiasm or a chunky chiasm, which is what my dosimeters like to call it. This is a slide from Netter, and again, a very important slide just to kind of get some basic anatomy. This is a sagittal view of the brain. We'll correlate this with MRI data. Again, here's the skull, the cerebrum, frontal sinus here. If we go down, we can see the sphenoid sinus. Here's the pituitary sitting in the sella turcica, and that is a very important landmark that's easily visible on MRI and CT data sets that you can use to help to delineate the chiasm. Again, the sella turcica, which is literally the Turkish saddle. Here's the clivus, which is part of the base of skull. Here's the brainstem, and we'll get into more detail on the brainstem in a bit. And here's the cerebellum, the posterior fossa. And again, this is a sagittal view, so we're not going to see much of the chiasm, but here it is right here. This little white structure here sitting directly cephalad to the sella turcica, sitting directly cephalad to the pituitary. And clinically you can tell that this is where it is because patients with pituitary adenomas that grow have visual field defects. The chiasm gets impacted. The minute this pituitary gets either a benign or a malignant growth in it, it hits the chiasm, and depending on where it's hitting the chiasm or the optic tracts, patients will have a clinical effect of this. Okay? So that is an important landmark that we're going to use to delineate the optic chiasm. So here's an MRI on a patient from my clinic, and you can tell it looks exactly the same. Okay? Again, cerebrum, frontal sinus is here, sphenoid sinus is here, and here is the sella turcica, again with the pituitary sitting right inside there, and right here, right above it, is the optic chiasm. Okay? Now we don't typically contour on sagittal MRIs or even sagittal CT data sets, but it's important to know where it is because you have all that data there. And in Eclipse or in whatever planning system you're using, you can look at it in coronals, sagittals, or axials. We're used to contouring in axials, but it's a good double check or triple check just to check the anatomy on the sagittal MRI or sagittal CT data set as well. So here it is on the axials, and I must say that we got lucky on this one, and this slide I picked specifically because you could see the chiasm beautifully. Here's the chiasm coming in here from the optic nerves, and then coming in here on this side, and then here's the chiasm itself, and then going back to the optic tracts. So this is where I would contour it. I would look for the sulci here as far as when I'm evaluating my fusion. We'd look at the orbits and make sure the optic nerves are fused correctly. And then we would use this to correlate. But again, we would always go back to the CT data set. And I would always, and the people who work with me who are in the audience, they need to plug their ears for a minute, but I always contour a little bit more aggressively. So the chunky or husky chiasm is on purpose. And then we'll look at the dose and then we might adjust that volume based on, depending on where the tumor is, or the GTV or PTV. So here's the CT data set from the same patient, and again, here it is on the axial slice. Now this one isn't as husky as I normally like to make it, but here it is, right here. It's just cephalad to the top of the orbits, to the optic nerves, and here it is on the sagittal, which again is the gut check. Okay, you can contour wherever you want here, but on the mid sagittal plane, you should be able to see the sella turcica very beautifully here, sphenoid sinus, and just cephalad to that should be your optic chiasm. So again, if we go back, the key landmarks for determining where the chiasm is are the sella turcica and the optic nerves. Both of those are able to be seen without MRI fusion. If you have an MRI fusion, even better. They're going to be even easier to contour. But here it is from Gray's Anatomy here. Here's the sella turcica, the pituitary sitting nicely in there. And again, here's a cross-sectional view of the chiasm sitting right above the pituitary and the sella turcica, and just posterior to the optic nerves. Okay, so let's move on to something a little bit more straightforward. This is the optic structures. Again, if we go back to the two trials that we're looking at, treating meningioma and GBM respectively, the dose constraints are fairly standard. 7 gray for the lens, 50 gray for the retina, and 55 gray for the optic nerves. Here's a sagittal view of the orbit, and here's the lens, which is usually pretty clear-cut on a CT data set, right? Another thing to pay attention to when you're looking at the lens is you'll be able to tell if a patient has a cataract. We'll still contour it, but we won't necessarily add a dose constraint on it, right? Because the endpoint for the lens is cataract formation. If a patient's already had cataracts, then we will contour it, but again, we would reduce the dose constraint. Here's the retina, this yellow line all the way around the orbit, going back into the optic nerve. And so the whole orbit is what we use. I call it orbit, you can call it retina. The goal is you got to know what you're contouring, what the constraint is. But the whole orbit is used as a contour. And here's a cutaway from Netter again, looking at the optic nerve. Now there are a lot of muscles that control extraocular movements, right? So there are a lot of muscles in the orbital orbit itself. But if you cut it away, you should be able to see one structure coming directly from the posterior aspect. This white line here, or this white structure here, coming from the posterior aspect of the eye, and that is the optic nerve. You should be able to trace it back into the optic canal and then to the chiasm. So here it is. I mean, this is pretty straightforward, but we should cover it just to be complete. Here are your lenses. And then again, we contour the whole orbit as the retina. Okay? And then here's your optic nerves coming back. And then here, actually, it's the optic canal, which we typically do contour it through the optic canal. And then posterior, here's where the sphenoid, here's the pituitary, here's the sella turcica, and just cephalad to that is going to be the chiasm, just cephalad and posterior to that. Okay, let's move on to the brainstem. It really is the control center for the brain. All signals going up from the spinal cord, all signals going down from the cerebrum, cerebellum, travel through the brainstem. It's the origin of the cranial nerves, and it's divided into 3 sections: the midbrain, the pons, and the medulla. If we look at, again, looking at the RTOG protocols and their dose constraints, 60 gray is the number that we typically use, but again, we base it on where we're treating, right? So for head and neck protocols, if you look, they have constraints for brainstem as well, but they're not 60 gray. The brainstem should not be getting 60 gray unless the PTV is very close to it, and so for head and neck protocols and RTOG, the dose constraints are less. And again, for meningioma, if you're going to a lower dose, you need to lower your constraint for your OAR. And of course, again, these are all based on a 0.03 cc volume. So again, here's our nice sagittal view again, which you guys are familiar with. Just reorient here. Here's the frontal sinus, sphenoid sinus. Here's the sella turcica and the chiasm just above that. Here's the cerebellum. Okay? And then at the top is the midbrain, part of the brainstem. In the middle is the pons, and inferiorly is the medulla. Okay? We'll cover some of the typical or frequently asked questions here in just a minute. So that's what it looks like on a sagittal Netter's drawing, and here's what it looks like exactly the same on a patient's actual MRI scan. You can see the midbrain very, very nicely, and the pons and coming down to the medulla. Here's the clivus right here, which is just in front, and what you can see also is that there is some level, this black stuff around here is all CSF. So there is some buffer around the brainstem when you're contouring it as well. So just keep that in mind. That's another landmark, although it's not a defined structure. So here it is on the axials, which again, we're used to contouring on axials. So this is a slice through the midbrain portion right here, and you can see the brainstem right here very nicely, just posterior to the chiasm. If we look at it on a sagittal CT data set, here's your sella turcica, okay? And the cephalad border that RTOG typically describes is approximately the posterior clinoid, which is right about in this area here for the sella turcica. So that's usually the cephalad border. And then the inferior border we're going to use is the top of C1, which again is a frequently asked question. Where do we start the brainstem? Where do we start the spinal cord and end the brainstem? And RTOG protocols help us with that, and they say the top of C1. Okay? So we're talking about posterior to the clivus here, which is this bony structure, the base of the skull. The cephalad border is usually the posterior clinoid, which is essentially the sella turcica. And then the caudal border is the top of C1. And then on the axial, again, you can use the sella turcica here. Here's the sella in an axial plane. And then this darker gray area here is all CSF margin. So when you add your PRV, so this is the actual structure, and then you'll add a 3 millimeter PRV on top of that. That'll encompass that CSF as well. And here you can see just the beginnings of the cerebellum down here posteriorly. Okay, if we move on to a little bit more advanced structures, we talk about the inner ear and cochlea. And I changed up the protocols here. I used a smattering of head and neck, recent head and neck protocols to kind of help us with this. RTOG 1008 is a post-op salivary gland protocol looking at radiation alone versus chemoradiation, prescription dose post-operatively, and again, the prescription dose is your typical 60 to 66 gray, and the OAR max that they recommend for the inner ear or cochlea is 50 gray. There's a protocol looking at nasopharyngeal treatment to a dose of 70 gray, and their dose was 55 gray to 5%, just again to use as a guideline. If we look here on Netter's, again, this is a bit of a complex drawing, but what I want to just really verify with you is that the anatomy on the CT data set and the MRI look like Netter's. That's really the goal of this presentation here. So here's the midbrain, here's the medulla here, and what you can see is that the cranial nerve 8 goes through the temporal bone here, and then into the cochlea, or the cochlea comes in this way. The point is that there's a defect in the temporal bone that's called the internal acoustic meatus, and that is basically what you need to find the inner ear. Okay? And then you can usually see the semicircular canals too. So there's the Netter drawing. That's what it should look like. And here's a CT data set. Okay? We're at the level, here's the clivus here. This is an axial CT data set. I kind of cropped it so that we could see a little bit more detail. Here's a CT data set at the level of the brainstem. Here's the clivus here. And as you can see in the temporal bone, there's a defect in the temporal bone. That's the internal acoustic meatus right here. And here's the internal acoustic meatus on this side. And having small kids, I've been told that this looks like Mickey Mouse. If you can see, so you look for Mickey Mouse. It's no different than, first grade. So you've got 2 ears here, and then here's Mickey's face and mouth here. And the same thing here. Here's 2 ears and the mouth. And again, you can kind of faintly make out the semicircular canals, which are back here. It's very difficult to give, without being able to window and level the CT data set. It's very hard to kind of show it and be able to scroll up and down. But trust me, it is there if you look hard enough and you have a good enough CT data set. So here's a paper. Again, we talked about Netter's, but we also talked about literature in the radiation oncology sphere that describes this, not for ENT purposes, but for our purposes, what we do on a daily basis. So there's a paper from 2005 in the Red Journal which shows this exact anatomy. And here's the internal auditory canal or internal acoustic meatus, and here's the middle ear, and here's how it is recommended to contour the inner ear or cochlea using those structures. And again, if we look at landmarks, which again is the goal here, one of the goals of the presentation was to look at the mastoid air cells, which again we did not describe, but they're very easy to see. You can see the mastoid tip. Here's the mastoid air cells. You can use that as a landmark. External acoustic meatus, which is just basically here, leading to the outside, and then the internal auditory canal, which is right here. So if you have those three structures, which are fairly easy to see, you can triangulate and figure out where the cochlea is. And again, you have to be, I find that it's better to look at this on bone windows, which will really kind of show the structures a little bit better so you can contour. Okay, moving on. If we go to the spinal cord, looking at two recent head and neck protocols, 1016 looks at oropharynx, P16 positive, treated definitively using a SIB technique from 52 to 70 gray. And 1008 looks at that post-op salivary gland protocol, again, going from 60 to 66 gray. The dose is a little bit different. And, I think, again, you've got the structure, you've got the dose OAR max of 48 gray at 0.03 cc's. And for the post-op salivary gland, it's slightly lower, 45 gray at 0.03 cc's to the PRV. And they give you a little bit of a buffer because you can get 48 gray to 0.01 cc's of the PRV. So again, here is a picture from Netter looking at the spinal cord. Now again, this is in the thoracic region, but it's very similar in the cervical region. What you can see here's the true cord. Now that is pretty tough to see on CT. It can be very challenging to see, and so that's why if you look at one of the more recent SBRT protocols, looking at spine SRS, I should say, they require an MRI because you need an MRI to see where the true cord really is. So if you can't get an MRI, I just had a patient last week with this scenario, he couldn't get an MRI. And so that protocol excludes patients who cannot get MRI. So because you can see, not all of this space is true cord, okay? So here's true cord, here's a little bit of epidural fat, you've got some CSF, you've got a lot of other structures here, and then you've got the nerve root here, right? When we talk about spinal cord, we're talking about this here as the true cord. Okay, so that's what it looks like in Netter. And here's what it looks like in real life. And it's very hard to see that detail on a CT. I mean, you guys know that. So here's what the protocol says. Contour what you think is the true cord and add a margin for a PRV. And that margin is 5 millimeters. Okay? So a little bit larger than the 3 millimeters we would use sometimes for the brainstem. But you can see, if you extrapolate this photograph to this, you can tell we've got good margin. So if we know what the dose is to the PRV, we know what the dose is to the cord. Okay? And from a practical sense, I think another option is to treat to contour just the thecal sac itself. Because again, you know that you've got some margin when you look at this structure as it's drawn versus this. Okay? So I think either one of those are options, and depending on the patient and depending on the dose and where the PTVs are, we may look at both of these options for patients. So we talked about, briefly, where the brainstem versus cord, and I think the top of C1, again, is the determination or landmark that I would use. And again, I think that's best viewed on the sagittal CT data set. We look at where the spinal cord ends. It usually ends around L1, L2, but again, you need an MRI to prove that, okay, to show where it ends typically. But I think that's a good landmark as far as if you had to answer something on a test or something like that. But you need an MRI if you're doing something clinically. So here's that same picture from the brainstem, and now I've added the cord in. And I think sometimes when you add PRVs, you can have overlap, and so that's another thing to kind of watch for. But here's C1, really right here, the atlas with the dens coming through. So the top of C1 is where I would cut off the upper cervical cord versus brainstem above it. Okay, the other structures to know about as far as landmarks for the spinal cord, again, basic stuff. Here's the vertebral body, just anterior to the spinal cord. Very important when you're looking at lateral films, or if you're looking at oblique films on a lung, that you know the relationship of the cord to the vertebral body itself. It's going to be just posterior to it. And then, of course, it's going to be anterior to the spinous processes. And L1, L2 is usually the caudal extent of the spinal cord. So if we go to oral cavity and lips, oral cavity, this is another structure that's really associated with a lot of morbidity. If you think about where a lot of head and neck cancer patients get into trouble, it's when there's a significant dose to the oral cavity. Sometimes it's unavoidable, but I think it's good to know what dose it's getting. And the lips as well. I think that's fairly self-explanatory as far as contouring the lips. But the oral cavity is defined as the anterior one half to 2/3 of the oral tongue, floor of mouth, buccal mucosa, and palate. And then the protocols, usually use a dose constraint of less than 30 gray mean dose. Okay? And the lip dose, they just say that you should try to keep it much lower than the oral cavity. So here is again a sagittal view of the from Netter's. Okay, so here's the nose. Here are the lips. Here's the hard palate, going back to the soft palate. Here's the oral tongue here. And here's the base of tongue and the vallecula. And here's the floor of mouth down here. Okay? So we're talking about really the anterior 1/2 to 2/3. So something like that is what it should look like. And again, the sagittal view is very helpful in determining what it looks like. It's very hard if you look at this side here, where to contour, where to start, where to stop. But I think if you look on the sagittal view, again, you can see the lips very clearly. You can see the hard palate very, very clearly. And you can extend it down so you know how much dose the oral cavity is getting. If we look at the mandible, again, a pretty straightforward structure. We look at the entire bony structure of the mandible from the TMJ through the symphysis. And these constraints that are used, again, in the head and neck protocol, 66 gray max or 64 to 70 gray max. And sometimes there's some inconsistencies in some of the protocols, but I think it's a good reference to just kind of look at as well. And here's, again, a straightforward picture of a ideal edentulous head and neck cancer patient. They never are like that, but that's what a mandible looks like without any teeth. And here's what it looks like contoured, straightforward. All right, if we move on to the parotid glands, we've got two, again, the same protocols here, looking at the contralateral dose of less than 26 gray mean, which is associated with a 20% complication rate. So that's the dose that we look at. And there are some other constraints, like 50% of one gland getting less than 30 gray, or 20 cc's total getting less than 20 gray, which is what the post-op salivary gland trial uses as well. So I think there was a recent paper looking at there's no dose threshold here. So as low as you can go is better. But I think if we use less than 26 gray mean is a good goal to strive for on the contralateral side, depending on if 1B is covered or not. And the parotid gland, as far as function, it's the major supplier of saliva for a stimulated state. So when you eat, or when the oral cavity is stimulated, the parotid is working very hard. So at rest, it's the submandibulars. So here's a picture of the parotid in situ from Netter. Again, you've got the zygoma, you've got the ear canal here. You've got the mastoid tip, which again has those mastoid air cells, pretty easy to see. Okay? And here is a axial view, which will be very helpful for us, because one of the things I see is that sometimes we miss the deep lobe of the parotid. We contour here, but we miss the deep lobe. And so here's the facial nerve, which again, patients will have trouble with their facial nerve if there's a parotid tumor invading, especially into the deep parotid lobe. Here's the mastoid tip with the mastoid air cells. And here are the structures that we can see very easily. The mandible, the medial pterygoid muscle, and the masseter. And sometimes you'll see the parotid drape over the masseter muscle. Other times you won't. But it should be pretty clear. And again, with a high-quality CT data set and appropriate windowing leveling, the parotids are pretty straightforward. So here is, again, a patient of mine with, here you can see the mandible. Here's the masseter muscle, right here, right where it should be. Here's the medial pterygoid. And here you can see exactly there's a different quality of the CT data here. This is the parotid gland right here. And again, it's not draping as much over the masseter as we saw in Netter's, but you can see there's a distinct change. It's It's a little bit heterogeneous, it's a little bit lighter, a little bit darker, but this is the parotid gland on an axial slice. So, and again, here's how we would contour it. Again, making sure that we come down into the deep lobe of the parotid to make sure we don't stop right here, to make sure we come down into the deep lobe. And the landmarks, so again, I would use that axial slice, that axial drawing from Netter's showing the mandible. Here's the masseter. Here's the masseter and the medial pterygoid here. And then you can see the, just cephalad to this will be the mastoid tip and the mastoid air cells. And then here you can see just a little sliver of the styloid process coming down as well. And you can use that as a landmark as well. Again, windowing and leveling is key here, and then obviously making sure you've got the deep lobe of the parotid as well. So the submandibular gland is the major producer of saliva in the unstimulated state, and it's very important for contouring target structures as well because it marks a delineation between level 1B and 2 as well. So the post-op salivary gland trial does not really recommend a dose, but I think the dose that's being recommended in the in 1016 is an ideal dose of less than 39 gray mean to the contralateral submandibular gland. Sparing of the ipsilateral gland is going to be very difficult, but we're really talking about the contralateral gland. Okay, and again, I didn't really spend too much time on digitizing pictures of this because it's pretty straightforward. If you window and level appropriately, you can see this triangular shaped structure right next to the hyoid bone. It's more anterior than the parotid and more caudal than the parotid, and you should be able to see it fairly easily. If we look at the larynx, it's defined anatomically by RTOG as a triangular shaped structure starting below the hyoid and extending to the cricoid cartilage from the anterior commissure to the arytenoids. Gosh, there's a lot of stuff in there, but the goal really is if you know a few key pieces of anatomy in the laryngeal area, it'll be pretty straightforward. And the mean dose, usually we think less than 20, less than 35, sometimes less than 45, again, depending on the proximity of the PTVs to the larynx itself. So here's another sagittal photo of the head and neck region, all right? So again, we've already started up here. We know where the lips are. Here's the hard palate. Here's the soft palate. Here's the oral tongue. Here's the base of tongue and the vallecula. And here's the epiglottis. This structure right here, this bony structure, is the hyoid bone. Okay, very important. It divides the epiglottis into the suprahyoid and infrahyoid epiglottis. And then here is the thyroid cartilage. So hyoid, and then thyroid, and then cricoid is down here. Okay? And right here, right behind the thyroid cartilage, in the area of C5 and C6, is the true vocal cord or the true larynx. So those are a few structures that you can use. And again, we talk about those templates and documentation. In our CT order sets, it's very clear that if you're simming a head and neck cancer patient, we want to make sure that they're not swallowing during even the simulation, certainly during the treatment, but certainly during the simulation as well. So this sagittal photo from Netter should be very, very helpful because these are all easily visualized on CT data sets. Here's a couple of contours. Again, here's the thyroid cartilage on an axial plane. Here's the thyroid cartilage on an axial plane, and then back here is the cricoid. And again, it's just a triangular structure encompassing that area. And here it is on a sagittal. This patient has a bite block in. Here you can see the mandible. Here's the base of tongue. Here's the vallecula. Here's that epiglottis. And here's the hyoid bone right here. Again, the hyoid divides the epiglottis. And then here is your thyroid cartilage. Here's your cricoid down here. Hard to see, but it's there. And so you can see it goes basically from the bottom of the hyoid bone to the cricoid, and then goes all the way back. Usually I'll just contour it all the way back to the vertebral bodies, but you can see to make sure you've got the arytenoids. So the landmarks I would use, C4 to C6. Here's C1, C2, C3, C4, C5, and C6, so that matches up pretty good. The hyoid bone is the cephalad border. Thyroid cartilage is the anterior border. The vertebral body, the anterior aspect of the vertebral body, and also the cricoid cartilage caudally. One of the newer structures is the posterior pharyngeal wall, which can be associated with dysphagia and difficulty swallowing from as far as long-term morbidity. And so this includes the posterior pharyngeal wall plus adjacent constrictor muscles from the inferior pterygoid plates to the cricopharyngeal inlet. And then there are some recommended doses, no more than 33% above 50 gray, mean dose less than 40. None of these are mandatory in the protocols. But here's how we contour it. Posterior pharyngeal wall. Uninvolved pharynx. And again, we ran into a little bit of issue when we had a protocol patient. You've got to exclude the PTV. If you're trying to meet these goals, there's no way you can meet them if you don't exclude the PTV from this volume. And it goes all the way from pretty much the base of the skull or the bottom of the clivus all the way down to the cricoid. And below that, it's esophagus. So moving straight to esophagus, you can reduce the dose. Again, the goal is to reduce the dose as much as possible. And they have some recommended goals, but nothing required. We still contour it on every patient just so we know where it's going, what dose it's getting. And again, here's the friendly sagittal view again. Behind the larynx is right where the esophagus starts. Okay? So here, this little slit coming down here is the esophagus, or the beginning of the cervical esophagus. Starts at the cricopharyngeus muscle. And it basically starts where your pharynx stops. And it extends all the way down to the thoracic inlet. The landmarks are the larynx, and remember the caudal border of the larynx is the cricoid, and the anterior border of the cervical esophagus is going to be the vertebral body. It's just basically between the larynx and the vertebral body there. And you should be able to see, sometimes you'll be able to see some air in there, but again, it's very helpful to be able to scroll up and down, and you can see, approximate or interpolate where it will be at starting. Okay, if we look at the brachial plexus, again, another anxiety-provoking structure, and there's a good paper from 2008, which is basically what I'm going to refer you to. If you look at the constraints, it's 60 gray to 66 gray, depending on if there are low neck nodes or not. At the end of the day, I think that you've got to watch out for gross disease in the low neck, whether that's going to be treated to 70 gray or if it's going to be treated with neck dissection. But anyway, there's some guidelines there. Here's a view of the brachial plexus, again from Netters. It goes from C5 to T1, basically, is where the structures are going to come out. From the nerve roots, come out, they jumble, and then they provide sensory and motor innervation to the upper extremity. Okay, so very, very important. And again, here's that paper from 2008. And I think part of the introduction is that everybody talks about the brachial plexus, but we don't have a standard way to contour it. And so I think you could talk an hour on the brachial plexus alone, but here's the reference that I use all the time to help me with contouring the brachial plexus. And so I refer you to that. And again, knowing some of the other anatomy in the area, I think will help you look at the brachial plexus with a little bit finer eye. So if we look at just a couple of other things, the scope of this talk was not to talk about contouring of target structures, lymph node levels, or anything like that, because again, I want to make it for practical stuff that you guys and gals do every day. But if we look at just a couple of landmarks that physicians may use to contour these target areas, we look at the vascular structures, and again, in a non-contrast CT, it's hard to see, but here's your carotid, here's your jugular vein here, and basically the lymph nodes, as you all know, they lie right next to the vascular structures. And so the lymph node target volumes are going to be around these vascular structures on either side. What I've contoured here is the sternocleidomastoid muscle, which is, again, a very important landmark for contouring the lymph node levels. Anything posterior to the sternocleidomastoid is typically called level 5. And so, again, that might be an area that's excluded or included based on the clinical scenario. The fat planes, you can see the nice dark areas here of fat. That's where the lymph nodes lie. They're going to be in these fatty areas around the blood vessels, coming back underneath the sternocleidomastoid muscle and posterior to it. And then the caudal extent of the border of the CTVs should typically be at the inferior aspect of C1 again. And then we also use those cartilages that I talked to you guys about, the thyroid, the hyoid bone, and the cricoid cartilage to determine the levels, lymph node levels that we're contouring as far as target structures. So if we were to summarize kind of what we talked about today, organ at risk contouring in the head and neck is a critical but highly variable endeavor. What I hope is reduce some of that variability, even interperson variability with this talk. There are a lot of resources out there that that exist to assist the radiation team, whether it's the physicians, dosimetry, physics. We're all on the same team here, and so I think a little bit of knowledge of basic and anatomic landmarks and relationships with, again, high-quality CT data will allow accurate and efficient contouring of OAR. Spending 2 hours on the chiasm is probably not a good idea, but I hope that with some of the anatomical relationships, you can make it quick, efficient, and accurate. So here are some of the resources that I use on a daily basis still. Again, Netter's Atlas, the red journal papers, the ones that I reference typically, the inner ear and the brachial plexus. The RTOG protocols I use a lot, and RTOG contouring atlases are there. They're mainly for target structures, but again, a good reference to see some of the basics as far as contouring. And it's kind of hard to find sometimes on the RTOG website. It's under Core Lab, I think, and then it's RTOG contouring atlases. And then web resources, there's a site, I've been looking at a couple other sites that I could use, and one of them is this eAnatomy site, which again has an iPad app, an iPhone app, a computer app that you can literally scroll through axial images, and there's an oncology section as well. You can scroll through axial images of CT data, MRI data, and look through it, and they've got probably 60 or 70 pins on every single CT data set, or every single slice, so that you can reference specific structures. So there's my email. If you guys have any questions, I'm certainly here right now, but feel free to email me as well. Thank you.